All right, so we're gonna get started. Just one very quick announcement for the people who had problems looking at the PDF with some of the equations. Betty reposted them as PowerPoint, so go back through them. And again, if you guys have any questions looking through them, please let me know. I'm going to email you one tiny little correction from one of the lectures that's not worth re-downloading the whole lecture. The next lecture incorporates a lot of what we learned in physiology over the last 4 lectures. It's a lecture on respiratory failure and mechanical ventilation. Our speaker today is Assistant Professor of Medicine, Daryl Abrams, who's one of our critical care group here at the hospital. Thank you.
Thank you, Bill. Good morning, everyone. Oh, perfect. Thank you. Okay, so I'm going to cover respiratory failure and mechanical ventilation. Is this? Oh, I got it. Great. Okay, I have no conflicts to disclose. These are lungs. So under normal circumstances, the purpose of the lungs is to exchange oxygen and carbon dioxide. Oxygen is going to diffuse from the alveoli into the capillary, where it's going to be bound to hemoglobin. You can see it turning from purple to red as hemoglobin passes through the lungs, and carbon dioxide is going to diffuse from the capillary across into the alveolus and be expelled by the lungs. So I want to start with a case to start with a situation of respiratory failure, and then we'll launch into our objectives. So let's have an 18-year-old woman with CF and severe bronchiectasis. She comes in with 3 days of productive cough with green sputum and increasing shortness of breath over the last 24 hours. She's brought into the emergency department. She's breathing 100% oxygen by face mask, by EMS. She's febrile, she's tachycardic, she's a little hypotensive, and she's tachypnic to 40. Her blood gas shows a pH of 737, a PCO2 of 71, and a PO2 on 100% oxygen of 238. But as the time progresses, she continues to worsen. Now her pH is 734, her PCO2 is 89, and her PO2 is dropping to 92 on the same amount of oxygen. At this point, she's emergently intubated. And this is what she looks like. Right? So this is a very common scenario we come across. This would be a very typical patient we receive in the ICU with severe respiratory failure with underlying severe lung disease. So my objectives for today, at the end of the lecture, I want you to be able to describe the mechanisms and types of respiratory failure, explain how to measure respiratory failure, describe the signs and symptoms of respiratory failure, and then its basic management. So going back to our picture from before of oxygen and carbon dioxide diffusing across the alveolar capillary membrane, respiratory failure is either a failure to oxygenate and or a failure to ventilate. As far as failure to ventilation, that's effectively a failure to remove CO2. We call that hypercapnic respiratory failure. The failure to oxygenate is hypoxemic respiratory failure. Generally speaking, hypercapnic respiratory failure or failure to ventilation is when the PCO2 rises above about 50 millimeters of mercury. And for hypoxemic respiratory failure, where your PO2 on room air drops below 60 millimeters of mercury. If you're giving supplemental oxygen, obviously your oxygen is going to be higher, but you may still have hypoxemic respiratory failure if you're not adequately diffusing oxygen from the alveoli into the capillaries. And either of these scenarios can be acute or chronic, and we're going to discuss how to identify acute versus chronic in this lecture. So I want to start with hypercapnic respiratory failure, which again is a failure of ventilation. So there's several causes of alveolar hypoventilation, which is how we characterize hypoventilation. It's at the alveolar level. So there can be either the I can't breathe or I won't breathe. Think of it in those two categories. So first, the I will not breathe, not able to breathe because there's no drive to breathe. So this can be from drugs if you're oversedated. It can be in sleep where your brain is not properly triggering the lungs to breathe normally. Or in the most willful scenario, you can think of someone breath holding. So that's a won't breathe scenario. Then there's the can't breathes. So if there's neuromuscular incompetence, you're trying to breathe, but there's problems at the spinal cord level or the peripheral nerve level. You're not triggering the respiratory muscles to contract. There's just muscle fatigue if you are, but the muscles are getting weaker and weaker over time. And then there's fatigue due to increased load on the respiratory system. So let's say someone who's morbidly obese, a lot of weight on their chest. You have to move that with each breath. And so you can have respiratory muscle fatigue from trying to move move air in and out with each breath because you can't expand the chest wall adequately, or with chest wall deformities where you can't expand the chest wall adequately. And then there's scenarios where something like increased dead space. And we're going to get back to that. So there's an inverse relationship between alveolar ventilation and carbon dioxide. We said hypoventilation, alveolar hypoventilation is equivalent to hypercapnic respiratory failure. So as alveolar ventilation decreases, CO2 goes up inversely. And the whole idea is that there's a balance between what you can do and what you need to do. So it's kind of like supply and demand. Your ventilatory capacity is the amount, the maximum amount of spontaneous ventilation that can be maintained without fatiguing. So it's how much you can do. And then ventilatory demand is how much you need to do. How much CO2 do you need to remove? So that what's your minute ventilation required to maintain adequate alveolar ventilation to keep your CO2 within normal limits? So under normal circumstances, your capacity far exceeds your demand. Okay? But hypercapnic respiratory failure is a consequence of either a reduction in capacity or an increase in demand, and that you're not meeting your needs. So going back to our causes of alveolar hypoventilation, you've got your decreased respiratory drive, neuromuscular incompetence, muscle fatigue. Those are all scenarios where you don't have the same capacity as you would under normal circumstances. Increased dead space, or where your air is going in and out of a certain part of the lung, but there's no blood flow. Okay, that's what dead space is. Just like the trachea, where there's no gas exchange in the trachea, that's dead space. In the alveolus, if there's no blood supply to that alveolus, a particular area, then that effectively is dead space. That's physiologic dead space. And if you have more of that, but you have enough, and you can't meet your demands, then it's an issue with not matching your ventilatory demand. Okay? Another scenario where you're not meeting your demand is where you're just producing more CO2, and you can't get rid of it under your normal capacity circumstances, or some other scenario where you're just producing, let's say, a lot of acid on the metabolic side, and you can't meet, and think of carbon dioxide as an acid, you can't get rid of enough CO2 to maintain normal pH. So that's where you need to do more to meet your demands, but your capacity is limited. Okay? So again, demand exceeding capacity. So what are the consequences of hypercapnia? Well, clinically, they can have CNS effects. You have anxiety, irritability, you can become confused, more stuporous, somnolent. Ultimately, if it's severe enough, you can die. And your cardiovascular effects, likewise, from high CO2, you can have hypertension or hypotension, depending on the clinical scenario. And you can have ventricular irritability, and one consequence can be ventricular arrhythmias. And it all depends on how bad the hypercapnia is, how rapidly the CO2 is rising, and how high it goes. Okay? So how do we distinguish? I talked before, hypoventilation or hypercapnic respiratory failure can either be acute or chronic. So how do we distinguish the two? So again, think of carbon dioxide as an acid, and elevations in CO2 are the equivalent of an acidosis, and if it's because of alveolar hypoventilation, then you would determine a respiratory acidosis as opposed to a loss of bicarbonate, which we'll get to in the renal section, which would be a metabolic acidosis. And the blood pH is determined by a balance of the CO2 and the bicarbonate produced by the kidneys. So when CO2 rises, depending on how fast it rises and over how long a period of time, the kidneys may or may not generate enough bicarb to balance your pH, to make that still an acceptable pH in the blood. You'll get to more of that in the kidney section, but that's what the kidneys will do to compensate for a rising CO2. So in the acute scenario, we're talking something on the order of minutes, perhaps hours, where the renal compensation is limited. It takes time for the kidney to make bicarbonate and to buffer that CO2 that's climbing. So in general, you're going to have a lower pH. You're going to have a pH under 7.3. It could be in the 7.1 range. It could be in the 6s range, again, depending on how high that carbon dioxide rises and how quickly. Chronic is on more of the order of days or longer, days, weeks, even months. You could have people with, very commonly with chronic hypercapnic respiratory failure. And assuming that their kidneys are able to compensate and they're able to make enough bicarbonate, you can get a pH that's closer to normal. You never completely match it, so you never get up to 7.4. If you have a primary acidosis, your compensation will get you close to your normal pH, but not quite. So you may see someone in the high 7.3s range. But that's more of a sign of someone who has chronic hypercapnic respiratory failure. So let's take two scenarios and see if we can distinguish acute or chronic. So two patients, both complain of shortness of breath. Both are breathing room air. They both have, one has a pH of 7.37, one has a pH of 7.2, but they have the same CO2 and the same PaO2. So which one is acute? Left? Anyone say left? Right? The right side, right. Because like we said before, the pH falls lower because you didn't have time to produce enough bicarb to buffer that pH, to buffer that rise in CO2, so they have a lower pH. The one on the left has a much more normal pH. Really, the normal range is 7.35 to 7.45, or a little bit narrower, but that's someone who's more appropriately compensated for a CO2 that's abnormal. And you look at the bicarbs and you see, sure enough, the bicarb on the left is high, the bicarb on the right is normal. And they have not had time to produce enough bicarb to balance that rise in CO2 and normalize their pH. Okay? So let me give you a few clinical examples of hypercapnic respiratory failure. Okay? So let's take a case of a 39-year-old woman, long-standing asthma, coming in with wheezing for 3 days. She's afebrile, she's tachycardic, she's tachypnic to 35, normal breathing rate, think in the range of 10, 12, okay, so much higher respiratory rate than normal. Blood pressure is normal, and she's satting 100% on room air. But however, she's audibly wheezing, she's using accessory muscles of respiration, and she appears very anxious. Okay? You give her 4 liters per minute of oxygen through nasal cannula, you give her an albuterol treatment through a nebulizer, and you give her some steroids. Pretty standard treatment for asthma. And you check a blood gas. Her pH is 7.55, acidemic or alkalemic? Alkalemic, right? Higher than 7.4. Her PCO2 is low, so she's breathing at 35 and she's hyperventilating, okay? And her PO2 is 135, which on 4 liters of nasal cannula is probably about right. However, an hour later, you check on her again. Key here is that she's somnolent, okay? She's no longer using accessory muscles, so she's not working so hard to breathe, but she's also not as awake and alert as she was before. Still afebrile, still tachycardic. Her respiratory rate is normalizing, and her blood pressure is still okay. So are you concerned? How many people think she's getting better? Good, okay. So a lack of hands was good. Her respiratory rate is normalizing, but she's becoming sleepier. So the next thing you want to do, let's check a blood gas, okay? Now she's 7.4, her pH is normal, PCO2 is normal, and PO2 is normal. So now how many people think she's okay? A couple more hands, okay. So some people think she's better. How many people think she's worse? Also a few hands, okay. So we're going to sit on her for an hour. We're going to come back and check her again. Now you can't wake her up. Good or bad? Bad. Okay, good. Her breathing, now she's rapid and shallow breathing, all right? So she's afebrile still. She's a little more tachycardic. Now her rate's up to 40. Now she's becoming more hypotensive. Anyone take a guess on what the gas looks like? Okay, 715, 65, 65. So now even though she's breathing at 40, she's not able to ventilate anymore. Rapid shallow breathing, a lot of dead space ventilation. She's only moving a little bit of air. And the key point here is you can have someone who vital signs look okay, but if you knew what they looked like before and now they're not getting better and they're slowing down, it's because the CO2 is rising and they don't have the same drive to breathe as they did before. They're getting more somnolent, one of the consequences of a high CO2, and now they're not able to keep up with their ventilatory requirements, their ventilatory demand, and their capacity is dropping. Okay, so there's that supply and demand difference. So this is someone who then would need to be emergently intubated for severe respiratory acidosis. Okay? And that's hypercapnic respiratory failure in the setting of asthma due to progressive respiratory muscle fatigue. As much as it is now the CO2 is higher, now she's more somnolent and maybe not, in the middle there didn't really even have the same drive to breathe. Okay? So let's take a different scenario. You've got a 55-year-old man with ALS. He's admitted for placement of a feeding tube. And his surgeon asks for a pre-procedure ABG, and he calls you to come and see him and comment on the ABG. Right? So he's seated in a wheelchair, he's breathing comfortably, he looks like he's at his baseline. He has diminished breath sounds at his lung bases on chest auscultation, and here his pH is 739, and he's the same PCO2 and PO2 as the last person. He's got a PCO2 of 65 and a PO2 of 65, but his pH is normal. Anyone think who thinks he needs to be intubated? Right, different scenario. The last one was someone who couldn't keep up with her ventilatory demand. Her muscles were fatiguing. She was getting more and more tired. This is someone who lives like this. You can see by the pH, he's had time to compensate. This is a chronic respiratory acidosis. This is his x-ray. He may not move a lot of air because he's weak, because his muscles aren't normal. His neuromuscular system is abnormal. But he's able to, over time, compensate for that hypercapnia with increasing bicarb and normalize his pH. So this is chronic hypercapnic respiratory failure due to neuromuscular disease. Two very different scenarios, and one person is an emergency, one person is at their baseline. Okay? Let's change gears and talk about hypoxemic respiratory failure. So this is a failure to oxygenate. Just always remember this, there are 5 reasons, 5 conditions that cause hypoxemia. Not diagnoses, but 5 kind of, scenarios within the lungs that cause hypoxemia. Alveolar hypoventilation, where you just, like we talked about before, you're not ventilating adequately, your CO2 rises, your PO2 falls, but they exchange in a nearly one-to-one ratio, such that as your CO2 rises, your O2 falls, but when you figure out an alveolar arterial gradient, it's normal. Okay? There's no actual intrinsic abnormality within the capillaries or the alveoli. You're just hypoventilating, CO2 climbs, and with partial pressures, think of it like there's only so much room for all the gases, CO2 climbs, O2 falls. A low FiO2 is another scenario where if you're at the top of Mount Everest, the FiO2 that you're breathing in is lower, and therefore if you figure out the alveolar arterial gradient and you use the partial pressure of oxygen in that environment, the FiO2, it's going to be low, and so your PaO2 is going to be low because you're not supplying your capillaries with as much oxygen, but your gradient is normal. There's no problem with oxygen diffusing across. You're just supplying less. Okay, so those are the two scenarios where you have a normal AA gradient but have hypoxemia. The other three are all problems with basically with gas exchange that lead to abnormal AA gradients. Okay, so in all 5 scenarios your PaO2 is low, you have hypoxemia, but in the last 3 you have an abnormal AA gradient, and that's impaired diffusion at the level of the alveolar and capillary, VQ mismatch, and shunt. Okay? As far as the causes, you can see hypoventilation is either pulmonary or extrapulmonary, depending on whether it's a problem within the musculature of the lung in the chest wall, or it's a problem centrally, like we talked about before. Low FiO2 is high altitude, but the other 3 are most commonly pulmonary causes, and shunting can be a cardiac cause as well if the shunt occurs within the heart. Okay? Hypoventilation begets hypoxemia, and many clinical scenarios involve more than one mechanism of hypoxemia, so just keep that in mind. And even though you may have identified one, there could be multiple occurring in one case, and we're going to illustrate that. So, is the saturation of oxygen on a pulse ox, let's say, okay, is that a good measure of hypoxemic respiratory failure? So let's take a couple scenarios and see. You take a blood gas of someone breathing 100% oxygen, their pH is 737, their CO2 is 71, and their PO2 is 238. You keep them on oxygen, they're getting worse, their pH is 734, their PCO2 is 89, and their PO2 is now 92 on the same 100% oxygen. So what do you think has happened with that patient's pulse ox? What's the saturation on the first person? What's the saturation on the second person? The first one is probably, you're going to get a saturation of 99, 100%, okay? But the second one, because the PO2 is still 92, even though it's a lot worse than 238, is still going to come out looking very high on the SpO2. And that's a function of the oxyhemoglobin dissociation curve, and the fact that as you get high enough with your PO2, your saturation doesn't change all that much. So your saturation in the first blood gas is all the way out there, far on the right side, and you're saturating nearly 100%. But the second blood gas, there hasn't been much change to the curve, so you're also saturating close to 100%. So it's not a good marker of someone's worsening hypoxemia if they're given a lot of oxygen. And just keep that in mind. The blood gas is going to tell you a lot more about their actual PO2 and how hypoxemic they may be becoming and how much worse they may be getting, even though the saturation may be reassuring. It could be falsely reassuring. Okay? And that's true until you really start to get to the shoulder of the curve where the saturation starts to fall, correlating with a lower PO2. Right around 60 is where you're satting about 90%, and then it really starts to drop off from there. Okay, what are the consequences of hypoxemia? So hypoxemia is low oxygen in the blood. That's why we say hypoxemia. But hypoxia is low oxygen to the level of the tissues. So there's CNS effects. There's impaired motor function, impaired cognition, decreased brain function, decreased brain stem function. There's cardiovascular effects. Every organ needs oxygen. So cardiac rhythm disturbances. You could be tachycardic, bradycardic. You can have arrhythmias. You could have myocardial depression. You could develop a myocardial infarction from not enough oxygen supply. You can go into shock as a result of that. And then other organ systems, kidney failure, liver failure, ultimately occur as the oxygen levels in the tissues drops and the oxygen supply for metabolic activity falls. Okay. As far as signs and symptoms of hypoxemic respiratory failure, in the acute setting, they could be dyspneic, they could get tachypnic, you can see cyanosis where the lips turn blue, the fingers may turn blue, they can start to get more somnolent. You may see asterixis where the hands are kind of flapping, they lose their attention, and that's what asterixis is. You say maintain your hands like this, and when they're doing it, they maintain it, but then they forget, it drops. So you can see that. They can seize, you can be tachycardic. And chronically, you can start to compensate for low oxygen levels. So you may produce more hemoglobin to maximize your oxygen carrying capacity and become polycythemic. So you see the red cell counts and the hemoglobin climb on a CBC. And chronically also, you may have developed pulmonary hypertension or cor pulmonale as the low oxygen levels that the lungs and the pulmonary vasculature are seeing cause increased pressures and increased resistance within the pulmonary vasculature, because as the pulmonary vasculature sees lower oxygen levels, it starts to clamp down. Its response is, oh, these areas aren't getting much oxygen, I don't need to use these areas of the lung that much. The lung is very self-conserving, and that, as a consequence, over time, that develops higher pulmonary resistance in the pulmonary vascular bed, and you get pulmonary hypertension. And as a result of pulmonary hypertension, the right heart can fail, and that's cor pulmonale. So some examples of hypoxemic respiratory failure. Pulmonary edema is a classic one. This is a pretty classic chest x-ray for it. That bat wing pulmonary edema, where you see a lot of infiltrate, a lot of haziness centrally, right around the pulmonary arteries. RSV pneumonia can be a more diffuse process. This is not pathognomonic for RSV pneumonia, but a viral pneumonia can look like this. Okay? And the acute respiratory distress syndrome is really bilateral infiltrates. It's acute onset, low oxygen levels, and it's not explained just by heart failure. And so you have someone like this with bilateral infiltrates on the chest x-ray. Let's say it's acute. It happened recently. And you see their blood gas, 725, 65, 65 on 100% oxygen. So clearly an abnormal amount there's clearly hypoxemia there. They're breathing 100%. Their PO2 is only 65. So they have a very large alveolar arterial gradient. So what are the causes of this patient's hypoxemia? And in these types of scenarios, this goes back to that chart. You can have a lot of those occurring simultaneously. So alveolar hypoventilation, shunt, and VQ mismatch can all occur simultaneously in someone with respiratory failure. Is the hypoxemic respiratory failure acute or chronic? We talked about hypercapnic and telling based on the bicarb and the pH. But you can't tell a hypoxemic respiratory failure acute from chronic based on a blood gas. All you know is if they're hypoxemic at that moment. The chronicity comes from the clinical situation, the physical exam. Is there evidence of that polycythemia we talked about with the high red cell counts, high hemoglobin? Is there evidence of pulmonary hypertension and core pulmonality? But in the moment, just by a blood gas, you cannot tell if it's acute or if it's chronic, okay, versus compared to hypercapnic respiratory failure, where if the pH is closer to normal with a high CO2, that suggests chronic. And if the pH is very low, correlating with just a rise in CO2, that's acute. Okay, so what happens if you don't intervene on respiratory failure? Well, let's take a scenario where we don't. 39-year-old woman, she's using heroin. She's brought into the emergency department in the back of the cab, and she's minimally responsive. She's afebrile, she's tachycardic, she's hypotensive, and she's not breathing normally, right? She's bradypneic, as we'd say. Her blood gas with the patient breathing 100% oxygen is 69, 180, and 85. Okay? So what do you think is going to happen if we don't do anything? It's hypercapnic respiratory failure, profound acidosis, and she could die. Okay. A 75-year-old man walks in, HIV, complains of severe dyspnea and cough for 1 day. On 100% oxygen, this is his gas. So he is ventilating. He's 75525. He has a respiratory alkalosis, but his PO2 is 45 despite 100% oxygen. Okay? That 45, hypoxemic respiratory failure, profound tissue hypoxia, and likewise can result in death. So serious clinical consequences if you leave these people alone. So what can we do to intervene? How can we fix it? Okay? So one thing you can do is give them 100% oxygen. We did that in the last scenario. It didn't really work. So hypoxemia from alveolar hypoventilation alone or even VQ mismatch will respond to 100% oxygen. Right? So as you wash out nitrogen, remember 79% of air is nitrogen. So if you give 100% oxygen, you're going to wash nitrogen out of the alveoli. So in low ventilation lung units, you're going to flood it with oxygen, and the PaO2 will rise. Because in those scenarios, with either alveolar hypoventilation or VQ mismatch, diffusion is okay. All right? The oxygen can get across the capillary. You just have to get the oxygen into the alveoli. Shunt is a different scenario. Okay? With shunt, it does not, by definition, shunt does not respond to oxygen. And this is a characteristic that defines shunt. So look at the left scenario. You're giving 100% oxygen. You're able to saturate the hemoglobin with oxygen, and then the capillaries leave all happy and red. If you're giving 100% oxygen in the scenario of shunt, and shunt meaning that there's blood flow, but there's no gas exchange. Okay, the air is not getting, or the oxygen is not getting to the capillary. It's just blood flow, no gas exchange. You can give all the oxygen in the world, and that oxygen is not going to get to the blood, and the blood's not going to be oxygenated. Okay, so if you had, in a very common scenario, you had someone who had a hole in their heart between the right atrium and the left atrium, so they have a right to left shunt. You could give all the oxygen in the world. That blood going from the right heart to the left heart without passing through the lungs sees no oxygen, and so it cannot pick up oxygen. So you can give 100%, and you're not going to improve oxygenation for that blood flowing from the right to the left. Shunt can happen in the lungs, and when that happens, same scenario. If you can't get oxygen to the blood, it's not going to pick it up. Okay. The other thing, the major thing we can do, which is what I want to get to next, is mechanical ventilation, intervening on respiratory failure. So what are the indications for mechanical ventilation and through that intubation? Progressive hypercapnia with fatigue, refractory hypoxemia, the two scenarios we talked about so far. But also if you can't protect your airway and you're worried about aspiration of gastric contents into the lungs, if there's a severe respiratory acidosis or metabolic acidosis, You may need to do it. In particular, with metabolic acidosis, you may need to ventilate them more than they can ventilate themselves. So that's that respiratory drive that we talked about with hypoventilation, where there's so much acid buildup. And even if it's metabolic, if you need to blow off CO2 to normalize pH, you may not be able to do enough on your own. So we may need to intervene, put someone on the ventilator, and increase their ventilation enough to be able to compensate. And so metabolic demand as well. If you're just breathing so hard and so fast, let's say you're in septic shock, you want to conserve all the energy you can. One of the ways to do that is to take over the breathing for the patient with the mechanical ventilator and let them rest and let them conserve their energy to fight off infection. So under normal circumstances, the respiratory system takes up a fraction, a couple % of your total metabolic demand. But in the setting of either severe respiratory failure, sepsis, where you're working really hard to breathe, it can be 10, 15, 20% of your metabolic demand, which is taking energy and oxygen away from other systems. And then sometimes just pulmonary toilet. There's so much stuff in their airway, you need to be able to protect their airway, get down there, and be able to suction things out, which they can't do on their own. Okay, under normal scenarios, under normal circumstances, without mechanical ventilation, we all breathe with negative pressure ventilation. Our chest wall expands, we create negative pressure in the pleural space, and that creates negative pressure in the alveolus, and air is drawn into the lungs. Okay? This is negative pressure, and that's the concept behind the iron lung, which they used to use as the way of mechanical ventilation back in the mid-20th century. And this was actually a very common scenario, especially in the polio epidemic, where people couldn't breathe because of neuromuscular failure. Okay? Under positive pressure ventilation, such as invasive mechanical ventilation, we are forcing air in. So we are creating positive pressure in the trachea that forces air into the lungs. That means the alveoli are under positive pressure, and the pleural space is under positive pressure because everything is being forced open by pushing air into the lungs. Okay? This is an example of what it looks like for the tube to be in the airway, and this is an example of a ventilator on the right side. Okay? Non-invasive ventilation is another form of mechanical ventilation, but to distinguish from invasive mechanical ventilation, which requires an endotracheal tube or a tracheostomy, you can also apply this non-invasively to the face with a mask, or sometimes you can use nasal pillows. These are both examples. Okay. In terms as far as inspiration, you can either be passive on the ventilator or active on the ventilator. But the vent is designed to reach a target, be it volume or pressure that you set. So if the patient is contributing to the work, such as on the right side, where they are still generating some negative pressure in the pleural space because they are spontaneously breathing even on the ventilator, they will pull air in. They're just having the ventilator do less work. Okay? When they're passive on the left side, the mechanical ventilator, let's say someone's heavily sedated, they're passive and positive pressure is being applied, like we said, into the alveolar space and into the pleural space. So in either scenario, they're invasively mechanically ventilated. It's just how much work the ventilator is doing relative to the patient. You can make the patient passive by sedating them, paralyzing them, or they can be active on the ventilator and it looks a little bit more like when they're spontaneously breathing, but they're still being assisted. As far as exhalation, it's the same as normal spontaneous breathing. Expiration or exhalation is passive. Okay? It relies on the elastic recoil of the chest wall and the lungs, and it's limited, just like in asthma exacerbation or COPD exacerbation, it's limited by the resistance of the airways and air coming out. Okay? As far as goals of mechanical ventilation, one thing like we talked about with high metabolic demand, one thing for mechanical ventilation is to rest the patient, adequately oxygenate them, meet their ventilatory requirements, meet that demand, and also maintain patient-ventilator synchrony. You don't want to put someone on the ventilator and have them desynchronous where they're fighting the ventilator and pushing against. Just like we talked about before, they can be passive or active. Many times the point is that you want them to be passive. You want to do the work for them, because if they could do it themselves, you probably wouldn't need intubation. So what does a mechanical ventilator do? Okay, and let's break it down into pieces. So it pushes gas into the lungs a few times a minute. That's the gist of it. That's the basic. Okay? So by pushing, we can set a flow rate during inspiration, how fast the air is going into the lungs. As far as the gas, we can set that. We set how much oxygen is going into the lungs. We likewise set how much of a volume goes into the lungs with each breath, and a few times a minute is how we set the respiratory rate. Okay? So we're pushing air in at a certain rate. That air, we are dictating how much oxygen it is. We're dictating how much air is going in and how often it is per minute. So this is a common flow diagram of what we call volume cycle ventilation. This is probably the most common situation of mechanical ventilation, the most common setting you're going to come across on the wards as you eventually get clinical and then go on to your residencies. And in the ICU, this is far and away the most common setting. So here we're setting flows, okay? So that flow, we can set how the flow is delivered, but basically this is your peak flow, and then it comes down. This is inspiration, and this is exhalation, which again is passive and set by the patient, okay? So by setting flow, we are determining the peak inspiratory flow. We also set the respiratory rate, how often that happens. And then inspiration, like I said, is that upward deflection, and then expiration is the downward deflection the rest of the time until the next breath is delivered. Okay? How much volume you give is, again, set by the ventilator, set by you. Okay? So you're setting a tidal volume. That tidal volume is in conjunction with how fast you want to give it. So you're setting both parameters. You're setting what you want to give and how fast you want to deliver it. Okay? The airway pressures are dictated not by you, but by the patient. And we're going to talk about how the components of those two. Okay? So in volume cycle ventilation, you set the flow, how fast it goes in, you set how much volume is going in with each breath, you set how often you want to deliver those breaths, but the pressure is dictated by the patient's airways and lungs. So the determinants of airway pressure during volume control or volume cycle ventilation, you'll hear both terms kind of interchangeably, is dictated by two sets of pressures. There's the pressure in the airways, and there's the pressure in the alveoli and the chest wall. So think of the airways, think of them as separate, okay? The airways, remember Ohm's law in physics, where pressure, or a delta P, a change in pressure V, is equal to flow times resistance, okay? V equals IR. So V is your change in pressure, is your airway pressure. I is your inspiratory flow, and R is your airways resistance. Okay? That's different than the lungs and the chest wall, where the pressure that's generated is dictated by compliance. How stiff or how soft are those lungs? When you deliver that volume, how easily do those lungs expand, and how much do they fight the volume that you're delivering? And that's dictated by both lung compliance and chest wall compliance. So we break it down into the two. We're setting flow, and we're setting tidal volume. So we're setting the inspiratory flow, but we're not setting the airway resistance. That's the patient. Likewise, we're setting the tidal volume, but we're not setting the compliance. So in these scenarios for volume cycle ventilation or volume control ventilation, you set those parameters, but the patient is going to be dictating the rest. So the pressures are not set. The pressures are a consequence of the flow and the volume, but then also the patient's lungs and chest wall and airways characteristics. Okay? So changes in pressure on the ventilator are going to reflect changes in the respiratory system mechanics. So if they get stiffer or they get more resistance in their airways, pressures are going to change for the same volumes and the same flows. Right? As far as PEEP, this is something that's maybe a new concept for you guys, but that is the end expiratory pressure, okay, the positive end expiratory pressure that is at the end of expiration. You set that on the ventilator, you determine what you want the PEEP to be, and that's when they finish exhaling. What does the pressure end up in the end? How much residual pressure is there in the system? The reason we do it is so that we don't let the alveoli collapse entirely at the end of exhalation. You never lose all your volume in your lungs. There's always a little bit of volume left over, and that's and under normal spontaneous breathing circumstances, all of you have some residual amount of PEEP in the lungs at the end of exhalation. We set that on the ventilator so that we don't lose that when we perform invasive mechanical ventilation. It also, if you up-titrate that PEEP, you may be able to open collapsed alveoli that are otherwise would otherwise be collapsed during invasive mechanical ventilation. So PEEP is set by you. As far as the peaks and plateau pressures, now putting them all together, okay? The peak pressure represents, again, the pressure in the airways and the pressure that you need to overcome for lung and chest wall compliance. So that's the total pressure in the system. You set the PEEP, you deliver a volume which results in a pressure in the alveoli in the lungs, and then you also add on the pressure in the airways. So you have PEEP plus the pressure in the lungs plus the pressure in the airways. That's your peak pressure in the system. Okay. So your airways, again, inspiratory flow times airways resistance, and the lung and chest wall is determined by the tidal volume over the patient's compliance. So can we use the ventilator to measure lung compliance? We can. Okay. So peak pressure tells you only the entire pressure within the system, but it doesn't tell you these two separately. Does that make sense? Okay. So in order to determine this one, we can do what's called an inspiratory pause. So here you have airways pressure and lung and chest wall pressure. When you do an inspiratory pause, it's at end inspiration, you close off the valve, you basically just press a button on the ventilator, you stop flow. So if you stop flow, there's no airways pressure anymore, and all you're measuring is lung and chest wall compliance. You've taken the airways resistance out of the equation. And so this line here is your plateau pressure, which still is a representation of the pressure in the lungs, which in part is additive with the PEEP at end expiration. Okay. So what are some problems with positive pressure ventilation? Well, cardiovascularly, because you're on positive pressure ventilation, the pleural space is under positive pressure, you may have decreased venous return to the heart, consequence which can be hypotension. As far as lung mechanics, this is one of the biggest problems we have with acute respiratory distress syndrome, is that you, by applying positive pressure with high volumes and high oxygen, high inspired fraction of oxygen, can cause ventilator-induced lung injury. And that's been well established in literature that the barotrauma of distending the alveoli every breath, and with or without free radicals from high oxygen levels, can cause worsening lung injury than we're already causing. It's kind of a necessary evil. We need to keep the patient alive, but the consequence can be worsening lung injury. And with that barotrauma, if the barotrauma is severe enough, you may cause a pneumothorax by blowing open the lung, by causing enough trauma that alveoli actually rupture. And also you can develop gas trapping in auto-PEEP, and I'm going to show you an example of auto-PEEP in a second. Also with gas exchange, because of the nature of invasive mechanical ventilation and how the volumes are distributed through the lungs, you may result in increased dead space or increased shunt. So here's normal inspiration and expiration, okay? The volume delivered, and then exhaled, and then the next breath, exhaled. And you see with each of these that with exhalation, the volume comes back to zero, okay? But what happens with auto-PEEP, or basically, so remember, PEEP is at end expiration. It's that pressure that's left over in the lungs at end expiration. You don't want the lungs to collapse entirely. But what happens if you don't exhale long enough and completely, and then you deliver another breath on top? If you keep adding a breath on top and you don't empty with the last breath, you're going to have residual volume in there, and with that residual pressure in the system. And that's auto-PEEP. So extrinsic PEEP is set by you on the ventilator. Auto-PEEP, or intrinsic PEEP, is what starts to develop as you start to breath stack, to deliver a breath on top of another breath on top of another breath without having emptied completely from the last breath. Okay? And that trapped gas is an increased pressure in the lungs that adds to and exceeds the PEEP that you set on the ventilator. All right, so as far as treatments of respiratory failure, the main thing is reverse the underlying problem. Invasive mechanical ventilation is supportive therapy. Like I just said before, it can lead to worsening lung injury by adding pressure and adding volume to the lungs that otherwise under spontaneous circumstances wouldn't be occurring. So you want to minimize that as much as possible, but at the end of the day, you need to treat the cause. What led them to respiratory failure that needed invasive mechanical ventilation? And then you also want to obviously support oxygenation and ventilation as much as possible. Keep their oxygen levels normal and correct their PCO2 so that their pH is within a normal range. Okay. So in conclusion, respiratory failure is a failure to oxygenate and or a failure to ventilate. They can occur in isolation or simultaneously, very often simultaneously. Hypercapnic respiratory failure results from hypoventilation, where the demand exceeds your capacity. Hypoxemic respiratory failure results from, remember, those 5 scenarios, those 5 situations of hypoxemia, 2 of which have normal AA gradients, low FiO2 and alveolar hypoventilation, and 3 of which lead to an abnormal AA gradient, shunt, VQ mismatch, and diffusion abnormalities. And positive pressure ventilation can correct hypoxemic and hypercapnic respiratory failure. So let's go to one more scenario, and I want to see what you think about this. You have a 46-year-old man with a dilated cardiomyopathy, status post-heart transplant. He's on immunosuppressive therapies, and he comes in with 2 weeks of shortness of breath, fatigue, and fevers. He's in distress. He's febrile, he's tachycardic, he's tachypnic, and he's hypotensive. This is his chest x-ray. Okay, so it looks pretty bad. Bilateral infiltrates. You can see the guy had heart surgery before. He has sternal wires in the middle. Okay, he's breathing 100% oxygen by face mask, and his blood gas is 744, 36, 81. So is that PO2 normal or abnormal? Abnormal, right? He's breathing 100% oxygen. His PO2 is only 81. Okay. So my question is, what's his AA gradient? How would you figure it out? And breathing 100% non-rebreather, most of it's oxygen. You get a little bit of entrainment from the atmosphere. He's not invasively mechanically ventilated, so it's not that all of the air going into his lungs is 100% oxygen. So one scenario is, can you take the oxygen off and measure an AA gradient on room air? That would be pure, right? That would be the best way to know his AA gradient for sure. but that's not safe. So don't do that, all right? Which is a common scenario on the floor. You've got someone who's breathing 100% oxygen and barely making it with that. His AA gradient could be 500, 600. You know it's abnormal. You know he's in severe hypoxemic respiratory failure. You don't need to do it for the sake of figuring out a number. You need to treat the patient, okay? And that it is a scenario that we've come across. So you know he's sick, and you don't have to prove it with calculation of a number. You probably, at this point, he just needs to be intubated. Okay. That's all I have. This is my email address if anyone has any questions about the lecture, any questions that come up. I'll be one of the small group leaders, so I'm going to see some of you guys tomorrow morning. Anybody have any questions? Yeah.
Just before we, there is a typo on one of the slides at the beginning. It's not FiO2 that is a cause of hypoxemia. It's PiO2. So you know
Sure.
your fractional concentration of oxygen on Mount Everest is still 21%. It's just 21% of a much lower atmospheric pressure. Right. So we'll correct that and upload
That's
it
right,
to
yeah.
Courseworks. But we have lots of time for questions, so ask away.
Yeah.
We think of hypercapnia as leading to hyperventilation, blow off of CO2, and yet you've described extreme hypercapnia leading to a depression of systems. Where do you draw the line?
Well, you're going to have a drive to ventilate more as the CO2 climbs, but it depends on what's the underlying process that's causing that CO2 to go up. So more commonly, I would define hyperventilation as blowing CO2 down to compensate for, under usual circumstances, a metabolic acidosis. There's other drives to be tachypnic and to hyperventilate, but one of the common scenarios is compensation for a metabolic acidosis. So the CO2 won't climb. You might be hyperventilating. You might be tachypnic, but you're not hyperventilating if the CO2 is up. That's still hypoventilation. It's out because that's what we call alveolar hypoventilation, where the CO2 is going up because at the level of the alveoli, CO2 is not being exchanged normally. Okay? So as that CO2 climbs and reaches some threshold that is different for each patient, that's when they may become more somnolent or have other clinical consequences. So it's more if acid builds up, you have a drive to breathe. If you can't meet that because your capacity isn't high enough to meet that demand, is when you're going to tip over.
And that threshold varies with chronicity. If we took your PCO2 up to 60, you'd be starting to get somnolent. That guy who had a PCO2 of 65, because he had ALS, he's been living with that for a long, long time. He's wide awake. He's crystal clear. He might not get somnolent until his PCO2
It's 100.
really got worse. It was 100 or 120. It all depends on how slowly you get there, how quickly you get there.
Yeah. Is that clear? Yeah, in the back. It won't help with pure shunt, no. It may improve your oxygenation and ventilation in other areas of the lung, so that may correct enough gas exchange to compensate for the areas of shunt. But it doesn't, the delivery of an FiO2 of 100% won't help in the region where there's shunt. So it just depends how much shunt is going on and how much you can compensate for that really elsewhere. And then also trying to fix the shunt. It may also induce shunt, because there may be, it may cause enough changes with positive pressure in the lungs that it may shift blood supply to more consolidated areas. So you may worsen shunt, you may worsen VQ matching with invasive mechanical ventilation. You hope that you're actually fixing it and not making it worse. Other questions? All right. Thank you.
I mean, you had time. I mean,
have like yeah. So when you have too much, you have like a low power. You have like such high EEG. Like I don't know if that causes hypoxia because like the cancer says that it does, but I think he says that it does. I'm gonna ask him. Dude, I think the respiratory physiology is way more challenging than cardio physiology.
It's interesting.
It's more interesting, but it's way more like you gotta think
What was
about it.
confusing about the lung units was that what I didn't understand was that when you were saying so you have like high and low, like that corresponds to like upper low treatment like you shot some and that's more important than yes, but it's just more like it's just yeah, it's bigger more than so I see something strange about like the low country being responsible for
It's fascinating how they get there. Quickly, bottom line. There's no flow. Between reps, if there's no flow, things are good and static. And that's an oversimplification because there's a mixing of gases and there's diffusion in there. But fundamentally, we try and boil everything down to as if there's nothing but laminar flow. And if there's no flow, if there's no washout, things are not going to change. It's also not true because blood continues to flow. So in between breaths, CO2 is going to climb, CO2 is going to climb. There's always a gradient. O2 is going to decrease, CO2 is going to increase between breaths. Between breaths, we're not changing any volume. So we've had a pressure change, we've gotten the volume change, and now there's no flow. And we're causing between breaths. There's no flow in the alveolus. Blood is continuing to flow. Right? So there's always a gradient of CO2 across the O2 wants to go across the gallons of gradient. There's always a gradient of oxygen going into the so things are really blood pressure.
no, not really.
Does not. Absolutely does not. But it is based in ventilation. Yeah, it increases your ortho breathing. The low BQ units drop your PO2. High BQ units don't help by increasing your oxygen level in the next layer. Right, exactly. Exactly. So you can have basically dead space ventilation. The person with emphysematous lung just has like a big tropical network. It's literally space. And ventilation is going in and out of that space. There's no capillaries in there. There's no blood flow. PaO2 from that space is 100. There's no 100, sorry. PaO2 is 100. But there's no blood flow at all. It's not doing anything. Yeah. Yeah, sorry. Yeah, you're right. So here to be and the major capital and nearby and any interaction the volume of so and that you see that happening all the time. Actually hypoxemic until they get really, really, really bad. So most people with emphysema start to get CO2 problems because they just can't ventilate enough to ventilate all this extra gas. Yeah, it starts to get that. Oh, what sort of effects is that? Work of breathing causes so somebody with mild emphysema can have a PCO2 of 40. And then they start to ventilate all this extra bed space, and they just like they start to get fatigued in a chronic way, and they start to tolerate PCO2 better because it's a lot less work to get to 50 than it is to try and breathe. This person with mild emphysema is breathing 8 meters a minute. Now we make that emphysema worse, and they need to breathe 10 meters per minute to keep it at 40. They're just going to say, screw it, I can't do it anymore. And the body just settles down like a pattern. That's when they get it is lots of diseases caused with mismatched poor ventilation and reproduction and the opposite. There's area wasted, but this doesn't cause hypoxemia. It's really the low units that cause hypoxemia. Yeah, it depends on the balance. Exactly. And there's some diseases where the balance is very even. Some diseases like chronic bronchitis, it's more of a ventilation problem. Some diseases like emphysema, where it's more of a perfusion problem. Usually it's like this, that's a problem. So the issue with this.
Hello, I'm the Navy rep today. I'm Taylor.
Hi, how are you? So, I'm not sure what happened with the last lecture. I guess it was already set up. Oh.
Really dead. Pulmonologists do this, and I'm not really sure what it's talking about. One thing that's really neat, if you Google, I don't know if I mentioned in the slide yesterday, go on YouTube and Google Nathan West and respiratory physiology, and he's from UC San Diego, he's still a professor. You can hear him give his own lectures. So if you read the chapter and then listen to him explain it, it's actually really fun. He has this cool British accent. Oh, really? Yeah. Oh, wait.
You can't walk around anymore because you have to use the mouse to point the thing.
Right.
So walking around was a laser pointer thing. No laser pointer, no walking around.
Yeah, I guess this is only quicker.
Yeah, but no one. The problem with the laser pointing doesn't get recorded.
Right.
So that's why
Yeah.
we're not
Thank
tethered.
you for keep looking out for students, because some lecturers just want to do their own thing anyway.
Well, it's fun to walk around.
Yeah.
But you have to do what you have to do.
10,000 steps a day and everything.
Well, that's true. It could be that we're not being physically fit then if we're not walking around during lecture.
For your own best interest.
Yeah, it's true. Well, I might have to bring that up with the university. No, I think it'll be all right.
Okay.
I'll try to stay tethered. I can do it.
Thank you. I think this is on.
And this
you also
clicks,
have
right?
the-
Oh, I see. I think I'm going to try to do it from here because that way I can point and click at the same time.
Perfect.
It does, believe it or not, actually, just to be fair, it does take a lot of retraining. So don't blame the lecturers that don't do it so much. It's really kind of hard, and so much so that you sometimes forget what you want to say because you're paying attention to the...
Yeah. No, I can't blame them. I was a teacher.
Yeah,
Not to medical students, but to sixth graders.
Yeah,
Walk around.
I'm not sure which is worse. Probably the sixth graders probably had their own...
I had to walk around, run around, just keep them sitting.
Yeah, it's hard. I mean, they don't get enough outside time anymore, so they're all so antsy.
Yeah.
You know. Yeah.
Absolutely.
It's really true. Well, that's a valuable experience.
All right, well, I'm there if you need me.
Thank you very much. I think we should get started mainly because there's a lot of material in this lecture. The other lecture that I gave was a little bit more, easy on time. This one is got a lot in it, and it's also followed up by the lab, which you'll see that there's been some attempt to focus on prototypical types of diseases that fit into different categories as you're learning them on the pathology side and on the pathophysiology side as different entities. And so there's been an attempt to do it. Not all of the pathology that gets discussed here is pathology that's discussed in the rest of the course, and there are pathology images and pathology topics that are interspersed into the other lectures, largely to offload this lecture in a way to make it a 50-minute lecture. The pathology of the lung contains within it some of the most common diseases that you will encounter, whether pulmonary edema, tuberculosis, lung cancer. These are among the most common things that you're going to encounter. But in fact, one of the things that I want to make clear to you up front is that a lot of the pictures that are in this lecture will seem old to you. And the reason is that much of the pathology that's described in this lecture, that is the underpinning of the diseases that you're going to learn about in other parts of the course, are not diagnostic pathology. This is classical pathology descriptions that ultimately led to the understanding of those diseases, but we don't actually sample tissues these days to make many of the diagnoses that are there today. And so I want to make a distinction between what we're going to talk about today, which is largely classical type pathology, which impacts on autopsy pathology, from what's diagnostic or diagnostic surgical pathology. And the two are quite different, and just keep that in mind. So the main goal, in the prior lecture, took you down the airway, and then we discussed some other things, vessels, etc. And we're going to actually follow a very similar pathway here, except we're going to talk about the dysfunction of those cells and those structures that we discussed in the first lecture as normal structures. What you're going to see is that there are diseases and disease states that really are focused on segments of the airway, as we used as that approach, and that there are structural correlates of that that are able to be visualized by imaging, but that there are also physiological consequences of damaging the airway at different points in its extent, and that those physiological consequences also classify the diseases. So in lung pathology, if you were to use a structural approach or an anatomical approach to classify the diseases, that would be very helpful for the most part, and then there would be a few exceptions that are largely physiological states that won't have a direct sort of external morphologic correlate, but would have a physiologic correlate. So, again, what I just said is encompassed in here. We're going to go from bronchi to bronchioles to the respiratory bronchiole and alveolus, and these are the diseases that we're going to cover as prototypes, and you're going to see examples of at least some of these in the lab. Then we're going to go to the alveoli, where largely the diseases are characterized by either luminal filling, that is replacing air with something else as a cause of the disease, or actually affecting the diffusion membrane of the alveolar wall. And in the end, we're going to discuss mass lesions, albeit very briefly, just because they're very common entities and they're in the lab as well. And we're going to talk briefly about disease of the pulmonary vasculature, because, again, this is an important part of disease states in the lung, including pulmonary thromboembolism, another very common problem. So I go back to the normal lung that I showed you in the first lecture. Again, pink, alveoli not readily apparent. And I used to use this as a picture of normal lung. Isn't it sad how hard it is to find an adult normal lung, that lung with that much anthracotic pigment in it and that much sort of brown discoloration is the closest thing one can come to normal, okay? That being said, the alveoli are not particularly apparent. The airways and vessels run in pairs, and you can see their size in relationship to the alveolar lung parenchyma. So it's not bad as a normal, but just to point out, it's not absolutely normal. So if we start off with disease of the conducting airways, meaning now the bronchi, we're going to talk about first bronchiectasis. Now, bronchiectasis is a state of injury of the bronchus. You can call it bronchiolectasia if it involves the bronchiole, but ultimately the cause of bronchiectasis is that the normal connective tissue structures that are in the wall of the airway get damaged, and they get replaced by structures that don't have the same elasticity and recoil behavior as the original structures. So rather than expanding and contracting as they're supposed to, they become fixed, and this is problematic. And so here is again a normal lung, and this is bronchiectasis. The alveolar lung parenchyma actually is largely lost in areas, and we'll go back to that in a second, but the most dramatic abnormality are these large cyst-like spaces, which really are, in fact, dilated bronchi. Now, over time, to get to a specimen that looks like this, or to get to a lung that looks like this, repeated pneumonias distal to that bronchiectasis will damage the alveolar zones and cause scarring, which is why the alveolar zones are gone. But the disease begins in the bronchus. And you can see that such structures, being that this is a structural type of an abnormality, can be visualized within the resolution of radiologic scans, even one that is not the highest of quality. Histologically, when we deal with dilatation of the airway, a normal airway, again from the first lecture, here at the bronchiole level, becomes dilated here, again, without cartilage, probably better called bronchiolectasia, but the airway becomes dilated. The wall can become thickened, but rather than muscle and elastic tissue, which allow for the contraction and recoil, it's replaced with collagen that's a fairly fixed structure and won't have that behavior, and so the structure becomes dilated. And remember, we perhaps ad nauseum talked about cilia and mucociliary elevator. Well, those cells become abnormal. The cilia no longer beat in the way they're supposed to for a variety of reasons, and I'll show you examples of that. And so there's mucostasis, and there's repeated infection. So you get dilatation, mucostasis, repeated infection, all of which damage the wall. Here's an example of so much mucostasis that it has actually extended into the bronchiole distally. So, for bronchiectasis, the gross pathology is a dilated bronchus that's filled with mucus or sometimes with acute inflammation, which you might call cloudy or purulent. The lower lobes are affected more than the upper lobes. Microscopically, often there's a lot of inflammation because, I said, there can be infection chronically in those airways and acutely. There will be some fibrosis in the airways, but the main finding is that the airway itself no longer has normal tone. And so it no longer sits its normal size. It becomes dilated. Diseases that are associated with bronchiectasis. And you can see that they're actually quite different diseases. There's cystic fibrosis, which alters the content of the mucin and of the secretion that's part of the mucus secretion, and therefore will cause a retention of the material in the airway. You can have a foreign body that impacts the airway that, again, will cause damage to the wall and repeated infection. Chronic bronchitis, generally in the setting of cigarette smoking with repeated infection, can cause bronchiectasis. And immotile cilia can cause bronchiectasis. Again, no mucociliary elevator, accumulation of mucus, repeated infection, damage to the wall, loss of elastic tissue, replacement by collagen. Okay? And so I showed you this image in the first lecture to show you the immotile cilia, which is the result of loss of the dynein protein in a subset of cases. Here's an example of lungs that were explanted in a patient with cystic fibrosis. Every one of these, green-gray, is that a good color for it? We okay with that? All right. I know that, there's controversy over blue versus gray in clothing, but I think so. I just want to make sure we're all seeing the same thing. I don't want to become an internet sensation on my inability to see color. But anyway, tan and green. Every one of these tan and green patches represents a dilated airway that has a mucopurulent secretion within its lumen. So you can see just how diffuse the process is, again, from an alteration that ultimately comes from abnormal mucin and abnormal secretion, actually, the watery secretion. Here's an example of lung with bronchiectasis, but you can see that the bronchiectasis is localized in the sense that there are normal airways in the same specimen. It's just sort of a localized dilatation. Here, the problem was a localized issue. Again, a cherry pit. So foreign body. So bronchiectasis is an anatomic description. It can have many causes. But again, ultimately the damage is to the conducting airway, resulting in loss of normal structure in that airway wall, and ultimately dilatation, mucostasis, and infection. So bronchiectasis is not in itself a disease. It's actually an anatomic description and the sort of product of injury that could be caused by several different diseases with a common target anatomically. And I want to emphasize that right now because, in fact, much of the injury that we see in classical pathology demonstrates the fact that the lung does not have a huge repertoire of responses to injury. Okay? It's inflammatory, it's fibrotic, it's recovery. And there are only so many different patterns of lung injury that you'll see, but when you take the big picture, you can sometimes deduce the diseases that cause them. And so here, the airway being the common denominator. Next, we're going to talk about chronic bronchitis. Chronic bronchitis has a clinical definition, which is listed here. It's often the result of smoking, and again, it often, or it is the result of smoking, it often results in repeated infections as well. Here's an example of lungs from a patient with chronic bronchitis. You can see this patient also has dilatation of the airways all the way out to the distal surface, but in fact the mucosa, which should be pink, here looks, I say, probably red-brown. And in fact, histologically, these airways are abnormal. And the abnormality that we see histologically in chronic bronchitis are a variety of things that happen to the airway wall that cause it to become thickened, that cause it to secrete more mucus, and alter the epithelium away from ciliated epithelium. And so again, normal airway cartilage, epithelium, lamina propria, and again this indistinct interface with the submucosa. And here, submucosal gland hyperplasia, massive increase in the size of the muscle also, you can see that. These are all chronic reactions to, again, chronic injury to the conducting airway. When we look at the epithelium, there'll be two findings. These are the normal goblet cells. There's goblet cell hyperplasia associated with chronic bronchitis. So patients with chronic bronchitis develop excessive amounts of mucus production. And you can see that is part of the definition. Not surprisingly, the airway is reacting to injury by creating more mucus. Because, again, that's the mechanism by which particles are cleared. Just eventually becomes pathological rather than truly adaptive. Here's an example of the wall showing more collagen accumulation in the basement membrane and thickened smooth muscle. And again, these are common things to conducting airway injury. But probably the most important thing to take away is that the epithelium, in addition to developing goblet cell hyperplasia, here the normal epithelium, ciliated, terminal bar, pseudostratified epithelium, almost inapparent goblet cells, which is what should be there. You shouldn't really see that many. Here, instead, the epithelium looks like the epithelium of skin. It's squamous. And squamous epithelium, stratified, even producing some keratin at the surface, does not have cilia. And so such an epithelium no longer provides the mucociliary elevator that's needed to clear the mucus. So the mucus is produced in excess, and the airway becomes maladaptively metaplastic and no longer is able to clear it. Okay? Again, I guess in some way of thinking about it, this type of epithelium is certainly more delicate than this type of epithelium, and perhaps this is an adaptive mechanism for chronic injury, of dealing with chronic injury, is to become more like skin than a more sensitive mucous membrane. Again, the gross pathology, the airways can be dilated and brown discolored. The bronchi should be filled with mucus. Microscopically, I think we went through this now, and it's just here for summary. The functional significance of chronic bronchitis is that the mucus, the edema, the narrowing causes airway resistance, and this will be in your lectures on obstructive lung disease. However, if you go back to the gross picture, not the best example, but let's look at the lower lobe. The alveolar zones themselves are relatively unaffected. So in fact, you get obstruction, but the lung capacity overall will be normal, again, with the idea that in some cases you'll have repeated pneumonias. You can lose alveolar zones from repeated pneumonias. But overall, the focus on the airway, not the alveoli. So capacity is maintained. So we now discussed bronchiectasis and chronic bronchitis as two diseases or disease states or structural abnormalities of the bronchi. We're going to move on to the bronchiolar transition. And so one of the diseases here that should be mentioned, you have a separate lecture, is asthma. Again, just definitions of bronchospasm associated with constriction of airways and other remodeling of the airways that happens in asthma. I like this slide because I find the dripping mucus very dramatic. It's clearly not in English, but nevertheless, you can see that the wall is thickened, the lumen is narrowed, so there are remodeling of the wall. There's remodeling. There are changes in the epithelium as well, but for the most part, it's in the wall of the airway, and in the lumen, it's accumulation of mucus. And so you can understand how the airways, which normally should be patent, will have an obstruction or a constriction in the luminal space. That's also a dynamic process. The smooth muscle also contracts. So the wall itself is thickened, but there's also more smooth muscle. The gross pathology of asthma is not particularly interesting. You can have very normal appearing lungs, frankly. And at autopsy, when we see a patient who would have severe asthma or status asthmaticus, and we haven't luckily seen this very often lately. These are, again, historical things more than modern things, but it still happens. The lungs don't look particularly abnormal. And part of the reason for that is one of the things that happens, which is hyperinflation, here shown on X-ray. You see the heart borders inapparent, the chest is enlarged from the hyperinflation. Once we enter the thoracic cavity during an autopsy, well, there's no expansion anymore. The lungs just collapse. And so we don't see that hyperexpansion at autopsy. We would see a lot of mucus in the airways, and that's a fairly typical finding in asthma. And here's mucus plugging, which, again, from retraction, from formalin fixation, the mucus doesn't look like it's filling the whole lumen, but in fact, the mucus is filling the whole lumen. It just sort of retracts when we fix and cut sections. So again, there's really occlusive mucus plugging here. And if you look at the airway wall, you'll see there's also submucosal gland hyperplasia, and there's some muscle thickening, not so different than chronic bronchitis, because again, the changes in the airway are somewhat stereotypical. They're not really that different from disease to disease.
Here's an example of a mucus plug, which is essentially the cast of a small airway seen on cytology, coughed up during an asthmatic attack. The epithelium in asthma, the main finding will be some thickening in the basement membrane, some smooth muscle thickening, but the eosinophils in cases of asthma that are allergic. Again, sometimes the basement membrane thickening and smooth muscle hypertrophy can be quite dramatic. And again, not necessarily specific for asthma, but will happen in other airway abnormalities. So grossly, mucus plugging and hyperinflation. Microscopically, there's hypertrophy of smooth muscle, inflammation, edema, and basement membrane thickening, all contributing to that thick wall in the cartoon. Okay? Again, total lung capacity will be increased during an attack with hyperinflation. There's airway resistance, so there's increasing work of breathing, and it is an obstructive lung disease. The airway resistance is increased on expiration more than inspiration. So now I want to briefly mention other injuries to the bronchiole, just because I didn't want the bronchiole to feel left out and only have one category underneath it. So not very nice for the bronchiole. But actually, bronchiolitis is one of these things that people talk about all the time, but we rarely see it pathologically, frankly. Viral causes of bronchiolitis, certainly pediatrics sees quite a bit of bronchiolitis that's related to viruses, but we don't really get pathology samples from that for the most part. Bronchioles can be involved in hypersensitivity reactions as well. But it's important to realize that, again, this idea that every segment of airway has a sort of prototypical response. The response is inflammatory, the response is fibrotic, the response can be hyperplastic. And in the bronchiole, unfortunately, a subset of injuries will lead to fibrosis. Smoke inhalation, some connective tissue diseases, and this is a problem post-lung transplant as well. And I just want to introduce the idea that inflammation is generally reversible. It's either self-limiting, or if it becomes persistent, it can be treated. But fibrosis is a problem. Once fibrosis occurs, it just is not, there is not a real easy way to reverse it, and even though there are some modern attempts to do so, this is still a field in its infancy. So reversing dense fibrosis, and you can sort of file that away. So here, for example, is a bronchiolitis. It's lymphocytic. It's part of a hypersensitivity pneumonitis to an external antigen, which you'll learn about as chronic hypersensitivity pneumonia or extrinsic allergic alveolitis in a later lecture. And here's an airway where you have to take my word for it that that should be an airway. It's hard to recognize because it's been completely replaced by fibrosis. And conceptually it's easy to believe that inflammation, if you were to get rid of the inflammation here, that the basic airway would still be intact, it would still have a lumen. But here, even if you were to get rid of the collagen, I'm not really sure that the normal cells are there, and you'd have to repopulate that airway with normal structures. Not the easiest thing to accomplish, okay? So again, just keep it in mind that these are the reasons why things become irreversible, all right? Okay, so I gave the 2 minutes to the bronchiole that it deserves, and we move on to down the airway to the respiratory bronchiole and alveoli. Again, trying to make sense of the fact that I sort of used that approach in the histology lecture, I'm going to follow it here in the pathology lecture. And so the disease of the respiratory bronchiole and alveolus that we're going to start with is really emphysema. Emphysema is an obstructive lung disease. It is the result of destruction of the wall, mostly of the bronchiole, but also of the alveolar wall. And we classify it by the pattern location of the damage to what we're going to call the respiratory acinus, okay? Now, as we went down the branch divisions that we talked about both in histology and in embryology, we ended up at the respiratory bronchiole. The respiratory bronchiole, which were lined by those club cells, represents the microanatomic structure that defines the acinus, which will be composed of the respiratory bronchiole, the alveolar duct, and the alveolar sac. This is the gas exchange zone. This is the zone where the cells become specialized to maximize gas exchange between the space and the vessel. Now, this is what we'll call the acinus. There's a type of emphysema where the injury, again, injury to the airway, results in loss of some of the connective tissue elements, especially elastic tissue, and the disease will damage the respiratory bronchiole, causing preferential dilatation of the respiratory bronchiole. This is a three-dimensional viewpoint, again, focusing on that acinus in its definition. Okay? We will call this centri-acinar emphysema. You will also see the term centrilobular emphysema, because some authors use the term lobule for the acinus. Okay? However, I avoid that because I use the term lobule in a different way diagnostically, and so I use the term acinus. Okay? But you'll see both, and they're both correct. Again, old picture, no one does this routinely anymore, but the understanding of this disease was founded on the idea that someone looked at these diseases and saw them in 3 dimensions but couldn't really think of them 3-dimensionally, so they made latex rubber casts of the airway. And that's what this is. And you can dissolve away the tissue, and what you're seeing is the respiratory bronchiole and alveolar ducts and alveolar sacs. Here in an early case, or earlier case, of centri-acinar emphysema, you see the dilatation of the respiratory bronchiole, but yet the sacs are still normal. As you get later on, this dilatation becomes even more severe, and the alveolar sacs start to become dilated as well. Okay? In contrast, injury can be more diffuse, and we will call that pan-acinar emphysema. We call it that because it involves the whole acinus. Okay? You'll see panlobular, but in fact, for whatever reason, pan-acinar seems to be the term people use more often, and centrilobular seems to be the term people use more often for reasons that are probably historical. But I can't explain it further than that. But again, here the dilatation is more diffuse. So, that leads to the question. I've told you that there's destruction to that segment of airway, but what causes the destruction? In centri-acinar emphysema, the destruction is caused by cigarette smoking. That the damage is to the respiratory bronchioles, and that you can get more diffuse involvement with more severe disease, and that it affects the upper lobes more than the lower lobes, and the apical portions of both upper and lower lobes more, apical portions of the upper and lower lobes more than the basal portions. Pan-acinar emphysema is damage to the entire unit. Now again, I think conceptually, damage to different parts of the airway from an inhalation are dependent on a variety of things. The way air goes through the lungs, the size of the particle, and whether the particle gets trapped in mucus. So cigarette smoking seems to attack the respiratory bronchiole, but here you've got something that's more diffusely involving the acinar unit. This is more diffuse, it is more severe at the bases, and the basis of pan-acinar emphysema is alpha-1 antitrypsin deficiency. So now we can talk about pathogenesis. And so the understanding of emphysema is really, really, really focused on the next 2 slides. In pan-acinar emphysema, the belief is that there's a balance that normally occurs between injuries that happen in the lung, which cause the secretion of elastases, and that these elastases are controlled by an anti-elastase activity from alpha-1 antitrypsin, and that every day we have injuries to our lung. We get inflammation, neutrophils will produce some elastase, but that our normal level of anti-elastase activity prevents that from damaging the tissue. Now, certainly cigarette smoking would be an injury that could accelerate that process for sure, okay? However, among other injuries. However, when alpha-1 antitrypsin becomes deficient in its function, neutrophil elastase becomes unchecked, and this causes the destruction in elastic tissue in the walls of the alveoli. Again, smoking causes more rapid evolution. But you understand that now there's an injury. The injury can be potentially diffuse within the alveoli, and there isn't enough anti-elastase activity to prevent damage to the elastic tissue. No elastic tissue, no recoil, and you end up with those dilated structures. That's a nice hypothesis which has been proved and is a very nice basis of understanding pan-acinar emphysema. Centrilobular emphysema is a little bit more complicated. In pan-acinar emphysema, the deficiency in alpha-1 antitrypsin is a genetic defect. It's an inherited disease. But in centrilobular emphysema, it's a more complex interplay of the injury from cigarette smoking, acquired deactivation of alpha-1 antitrypsin activity, maybe more than just neutrophil elastases. Maybe there are proteases coming from other cell types. And they're not only elastases. There are a variety of other proteins, including ones that would be pro-inhibitory, pro-inflammatory and destructive, and also potentially loss of inhibitors of protease activity. All are very complicated and much more beyond the scope of what we're going to talk about today, but the outcome is the same, which is that you get destruction of elastic tissue and in the wall of the airway, here focused on the segment of the airway which is most targeted by the particle size involved in cigarette smoke. Okay? So in the gross appearance of emphysema, again, I emphasize that you do not see alveolar spaces in a normal lung at arm's length. In emphysema, the alveolar spaces or the dilatations are quite dramatic. And you can see them here, a case of central lobular or centriacinar emphysema with worse disease in the upper lobes. Histologically, it's really hard to tell the difference between an alveolar sac, an alveolar duct, and a respiratory bronchiole. So normal alveolar space, what we see histologically in emphysema are just dilated spaces. You can see a relatively normal one here alongside these largely dilated spaces next door, which are the histologic correlate of what happens if you take a section through a big patulous open space like that, right? I mean, you can't do a histologic section of a space. You end up with space, right? Okay. All right, so gross pathology, irregularly dilated air spaces. They're thin-walled and grossly apparent, microscopically dilated alveoli. And certainly in central lobular emphysema, you'll see the anthracotic pigment from the cigarette smoking. And certainly if a patient with panacinar emphysema smokes, you'll see it there too, but they don't have to smoke to have emphysema. It certainly accelerates their disease if they do. So again, in contrast, centriacinar versus panacinar, upper lobe predominance grossly in centriacinar and upper portions of the lower lobe, thin-walled and grossly apparent, irregular spaces. Again, histologically, not really just dilated spaces, anthracotic pigment. The distribution of panacinar emphysema, again, is more lower lobe, but again, because the disease involves the entire acinus, the disease is more uniform and diffuse. Now, you might look at central lobular emphysema and say, well, there's these big spaces alongside small spaces. But in fact, the diffuse nature of panacinar emphysema makes panacinar emphysema actually have quite a bit more volume than central lobular emphysema, because the dilatations, while smaller individually, are just far more diffuse. Oops. And here's an example of a type of section which was done during the 50s and 60s. They're called Goff sections. Somebody had this type of instrument that could, take a section from an entire lung and just mount it. Just like we do a slide, but it could do it for an entire organ. It's kind of a neat thing. Nobody has it anymore, I don't think, but it is kind of a neat thing. So you're able to actually see from top to bottom the fact that there are markedly dilated spaces here in the upper lobe and in the apical portion of the upper lobe, and the dilatations are worse than in the basal portions. And again, both in the lower lobe and the upper lobe, there are dilatations, but more dramatic in the upper portions. You can see the anthracotic pigment. Here, a case of panacinar emphysema where the dilatations, although individually smaller than in central lobular, diffuse throughout and arguably a little bit more severe in the lower portions. So again, summary slide. Not going to go through it again, just to remind me that I made sure I went through everything I wanted to say. All right. So another point which is really shown by this diagram is that why is it an obstructive lung disease is a question that you should eventually think about as you go through the pathophysiology. Certainly, if there's an airway component, say the equivalent of the chronic bronchitis sort of scenario, you can understand that, the wall is thickened, the epithelium, there's mucus. That part of it could be obstructive. But what I just showed you was far more an alveolar respiratory bronchiole problem than a mucus plugging problem. And what's felt to occur is that the tethering of the airway is damaged in emphysema. And so while in the normal setting, airways are kept open during expiration, in emphysema, because there are all these breaks in the elastic tissue, the airways actually do not remain open during expiration. So they can be open during inspiration, not during expiration. Okay. So in emphysema, there is an increase in total lung capacity. Because of the destruction of elastic tissue, lung compliance is increased. Small changes in pressure result in large changes in volume. They're in pure emphysema. There's a maintenance of the airway and capillary structure, so the VQ mismatch is not severe. In chronic bronchitis, it is. And recoil is decreased from the loss of elastic tissue, so you lose the radial traction on the airways, and this becomes an obstructive lung disease. Okay? All right. So, I've taken you through the conducting airway, and I've taken you all the way to the respiratory bronchiole, and we touched a little bit on the alveolar sac, but I wanted to really emphasize the respiratory bronchiole because, and I wanted to emphasize also the fact that of all the diseases, emphysema still is an obstructive lung disease because I've gone through the pathology of the obstructive lung diseases actually just now. Okay? And now we're going to move to the alveolar zone. And so in the alveoli, you can, as I mentioned, fill the lumen with something, and those things can differ. We'll go through that. Or you can expand the interstitium, and from a simplistic point of view, not that simplistic, it's either fibrosis or inflammation. Okay? So this is a carefully drawn diagram. Actually, no. This is actually a drawing from one of my colleagues' son when he was little. He came to his, sort of come to work with dad type of a thing. And so, in a pathologist's office, there's a limited repertoire of coloring books. So he gave him some type of pathology book that had pictures, nothing too gross, I hope. And I'm sure he picked the page and he picked lung, and so this is how Dr. Markowitz's son drew a set of lungs. Why are the lungs blue? Well, I asked him that. Well, because air is blue, right? Obviously. Okay? So we understand this, even at a very young age, that the lungs are supposed to be filled with air. Okay? All right. So if you replace the air with something else, bad things will happen, right? Bad things will happen because you will no longer have air in the lungs, but you will also wash out things like surfactant that keep the air spaces open. And this, changing that is problematic as well. So, for example, the prototypical disease of luminal filling or pulmonary edema, usually from left heart disease, although it can happen from non-cardiogenic causes, is the filling of alveoli with fluid. And so, again, normal lung in pulmonary edema, because oftentimes it's from the failure of the left heart, there's accumulation of some blood in the interstitium, but the lungs will become heavy because the density of water is higher than the density of air. And histologically, you'll see the congestion because, again, there's left heart failure. But you'll also see the luminal spaces, rather than being filled with, sort of clear space, having this pink material which reflects fluid accumulation. And this is the histology of pulmonary edema. Fairly straightforward. Again, grossly, the lungs are heavy and wet. Edema, fluid in the alveolar spaces, more severe in the lower lobes, again, because of the pressure issues that are involved, and the alveolar walls will be congested. Pneumonia, which is really inflammation of the lung, although when we talk about pneumonia with each other in a sort of, cocktail party kind of way, we're usually using that in the setting of an infectious process. But nevertheless, the general definition of pneumonia is inflammation of the lung, which is why you'll hear about interstitial pneumonias, which are non-infectious. But most of the time when we talk about pneumonia, we're talking about infectious types of pneumonia when we're talking to our friends and folks, who are non-medical. When we look at a normal lung, in the case of pneumonia, again, this being the normal lobe, this lobe is discolored, it's gray. If you were to palpate it, and you should have one in your lab, the lobe will be firm. It's firm because, again, the air, which used to be there, which would make it spongy, has been replaced by either some type of cell and fluid. And so here, firm, discolored, there's a little bit left of normal lung at the bottom. We will call this a lobar pneumonia. In contrast, some pneumonias will be more patchy and won't involve an entire lobe, and we'll call that a lobular or bronchopneumonia. And the pattern is somewhat dependent on the pathogenicity of the organism and the host, but the histology is very similar between the two. It goes through stages. In the acute stage, there are neutrophils that fill the alveolar space, neutrophils and some fluid. And so, in fact, this is the alveolar filling with inflammatory cells or neutrophils, which is acute pneumonia. Again, consolidation. In lobar pneumonia, an entire lobe in lobular or bronchopneumonia in patches. And again, the acute bacterial pneumonias, whether they're lobar or patchy, have PMNs or neutrophils filling the alveolar space. Pulmonary hemorrhage is the filling of alveolar spaces with blood. And as products of coagulation will do, there's often fibrin along with the blood. With time, with repeated hemorrhage, the products of blood cells which contain iron will produce iron deposition or hemosiderin within the lung, which reflects more chronic component of hemorrhage. Pretty straightforward. Certainly pulmonary edema looks red, but hemorrhage looks redder. Okay? And because the lungs are now filled with blood, not just fluid, and it's not just congestion, it's frank blood. Histologically, while you can see red blood cells in the lung just from sort of physically altering the tissue as it's taken out from sampling, fibrin is not part of that, and fibrin indicates an active hemorrhagic process, and so you're seeing red blood cells and you're seeing fibrin as well within the alveolar space. With chronicity, there's accumulation of iron in macrophages, which is this brown discolored material, which we call hemosiderin. So again, fairly straightforward replacement of alveolar spaces. Now, in addition to traumatic lesions, like a knife wound or something causing bleeding, bleeding will also result from damage to the vessels themselves, and some of those cases will be immunological, and there are immunological diseases that can cause pulmonary hemorrhage. ARDS, diffuse alveolar damage, is an acute alveolar injury with microvascular damage. You get edema and tissue injury. In addition to edema, there are injuries to the epithelium which result in necrotic material in the alveolar space, which are called hyaline membranes. Again, it's still a disease of luminal filling, but it also has an interstitial component because it damaged the alveolar capillary membrane. You're going to hear more about that in the corresponding ARDS lecture. Going out of the luminal filling, and again, in a way, ARDS is a transition from a disease that is pure luminal filling, like these three, to one that has a combination of luminal filling and interstitial disease. Okay? In interstitial disease, these prototype diseases, UIP, sarcoid, and hypersensitivity pneumonitis, will be discussed in your ILD lecture next week. This picture will be in that lecture. And so the only point I want to make here is that the alveolar wall, a thin, nice membrane for gas exchange, can be expanded here by collagen, which has been stained on a trichrome stain, so the collagen stains blue, or by inflammatory cells, which here are mostly lymphocytes. And again, irreversible, reversible. Okay? All right. Mass lesions of the lung. Again, it's not talked about a lot in this course. I'm sure you talk about granulomatous disease in your infectious disease course because the prototype there would be tuberculosis. And I know that you'll be discussing malignant tumors in the oncology course. But again, just to briefly show mass lesions, again, they're localized, not diffuse. They're distinct from the adjacent lung parenchyma. The central necrosis here is part of the central necrosis or caseation that's described in tuberculous granulomas. Here in an adenocarcinoma, we'll call such a structure umbilicated because there's a cellular proliferation at the edge and a scar in the center. So the center sort of is a bit depressed, like your belly button. Okay? And so granulomatous disease is a mass with a rim of histiocytes and necrosis in this case. They don't have to be necrotic, but this one is. And carcinoma represents a disordered growth of epithelium here forming glands or an adenocarcinoma. I want to spend the last few minutes talking about disease of the pulmonary vasculature. I had 3 cups of coffee this morning instead of 2, so I seem to be moving along pretty quickly. And so we're going to talk about pulmonary embolism, pulmonary hypertension, and vasculitis again. You probably have separate lectures on pulmonary embolic disease and pulmonary hypertension. So the main focus here is to show you the pathology of it, not to really talk about the diseases a whole lot. And I just want to mention vasculitis because we mentioned hemorrhage, and I'm not really sure where vasculitis fits into your curriculum. So pulmonary embolism is obstruction of the pulmonary artery, usually by thrombus. But it doesn't have to be thrombus. There are other things that can be embolic into the pulmonary circulation. Fat, amniotic fluid, during a delivery, and obviously with bad outcome. Cancer cells can embolize along with clot. And so there are other things. Infarcts are really necrosis of tissue. And in spleen and in kidney, you get these characteristic types of infarcts if you occlude the vessels, because those are end circulations. There's no second circulation in those. And so if you occlude them, they infarct. Pulmonary infarcts happen as well. And it is also coagulative necrosis due to ischemic injury as the result of the embolus because of loss of blood flow to the lung tissue. So most of pulmonary emboli arise from deep venous thrombosis in the lower extremity. It can happen in other veins as well, pelvic veins, occasionally upper extremity, but mostly the lower extremity. Big ones can occlude the pulmonary artery at the bifurcation, causing sudden death. Okay? Now, infarcts do not occur in the lung from emboli in the majority of cases. Okay? Because like I mentioned briefly just now, spleen and kidney are end circulations, but we talked about the fact that in the lung there are two circulations. There's the pulmonary artery circulation, and there's the bronchial circulation. And so when emboli occur, they're occluding the pulmonary artery branches, and there can still be blood supply from the bronchial circulation. So while the vessels are occluded, the tissue doesn't infarct because it can still get a blood supply from the other circulation. However, they do occur. They occur in cases where the dual circulation is impaired. If you have severe aortic atherosclerosis and your bronchial circulation is poor, then you're not getting that much blood from that source, and I suppose there's anatomic variation as well. Again, eventually, if you don't have a large embolus resulting in sudden death, small emboli will organize and they'll recanalize. However, chronic pulmonary emboli, they can result in incomplete recanalization, and you can develop elevated blood pressure in the pulmonary circulation from chronic pulmonary embolism. So here's really the main point of showing this is really to give you a feeling for just how big pulmonary emboli are when they are saddle emboli. I mean, here's a heart, the aorta's been removed. You can actually see there's some clot in the superior vena cava, but I'm asking you to ignore that right now and to focus in on this thing that's sitting within the pulmonary artery. Okay? In fact, it extends not only from the pulmonary artery, but it continues here into the right ventricle. Okay? These pulmonary emboli are enormous, okay, or can be enormous, because they've formed in fairly large structures. The veins that are in your lower extremity are large, and they're a cast of that structure. Now, smaller ones can break off, and you can get smaller pulmonary emboli, and that can happen, but when this one breaks off with this size, you can understand why it could suddenly impact circulation. Okay? Here we have a valve marking of where the thrombus formed within the channel of the vein, and this is actually the marking of where the vein had a valve. And so again, true emboli will be a cast of the vein they came from, including the cast of the valve. Here's an example of a pulmonary infarct. Pulmonary infarcts are wedge-shaped. They're often hemorrhagic because they do bleed into them even though the circulation is not completely impaired. It's impaired enough to cause necrosis, but there is still enough blood flow to bleed into them. So they're usually hemorrhagic, pleural-based, and wedge-shaped or triangular. Now, here's an example of an infarct histologically. Coagulative necrosis. You still see the architecture of the lung here, but there are no more nuclei. This is viable lung. There's a rim in between, and you see the architecture of the lung, but no nuclei, and that's what coagulative necrosis is. Okay? The structural elements remain, but the cells die. Here's an example of a different type of embolism. Here, not thromboembolic, but in fact, in an intravenous drug user, talc intermixed with intravenous drugs, here polarizable. So not only thrombi, other things can embolize, and in that case, foreign material. Disease of the pulmonary vasculature, pulmonary hypertension, again, you're going to have a separate lecture discussing this, but in summary, abnormal elevation in blood pressure in the pulmonary arterial circulation. Grossly, we'll see pulmonary artery atherosclerosis and dilatation in pulmonary hypertension. Right ventricular changes can be seen as well, depending on how long the chronic disease has been. Microscopically, we see progressive abnormalities in the blood vessel that are related to the severity, duration, and cause of the pulmonary hypertension. And there was a system many years ago designed to classify this, and the system has a little bit less relevance today in many ways. It was designed mostly for congenital heart disease and irreversibility of pulmonary hypertension in that setting, but things have changed a lot. But we still use the system because it has some utility in grading the lesions. And so this is diagrammatically from normal vessel to intimal thickening that's more severe, to actual segmental injury and necrosis of the vessel, to aneurysmal dilatation and thrombosis with recanalization as steps of injury in the pulmonary artery. And diagram now in sort of histologic section, the normal vessel, again media, internal elastic, external elastic, normal vessel. Here an example of a vessel that's showing some concentric thickening where the lumen is starting to become occluded from intimal and medial thickening. Here's an example of a blood vessel in which part of the wall got damaged by the elevation in pressure, ultimately leading to aneurysmal dilatation and recanalization, again, the actual and versus the diagram. Here's an example of a sieve-like proliferation, which is the highest, or one of the, let's go back to the grading system, is in this grade 4 and grade 5 lesion, and we refer to that as plexiform arteriopathy. Now, we distinguish that a little bit from this because this is more of a primary lesion of proliferation that's causing occlusion of the vessel and is the histology of forms of primary pulmonary hypertension that occur in young women. Lastly, I just want to show an example of inflammation of the blood vessels. Certainly vasculitis, which is inflammation of the blood vessels, occurs in the lung. It can be immune-mediated or it can be secondary or infectious. In either event, the normal vessel becomes, especially in immune-mediated vasculitis, segmentally damaged by an inflammatory infiltrate, resulting in necrosis of the vessel wall in a segmental fashion, and these are the inflammatory cells, neutrophils, and lymphocytes. So with that, I've taken you through the airway lesions, obstructive, restrictive, filling, all alterations. Interstitial disease is going to get discussed in a separate place, as will ARDS, the pathology of vascular disease, and it gets you set up for the specimens in the lab, which, especially the gross specimens, this is a unique opportunity for you to actually hold the disease in your hand and to think about how it would look and how it would look by imaging and other techniques that you're going to actually in the future be encountering those diseases. Thank you very much for your attention.